Thank you for your kind introduction, Chairperson. Good afternoon, everyone. I'm pleased to speak with you today about the role of cardiac MR and patient with the coronary artery disease, CAD. Before I begin, I'd like to declare that I have no conflict of interest related to this presentation. Today, my talk focused on the myocardial evaluation in patient with CAD, and I will explain how CMR assesses the myocardium using two core techniques, late cardiac enhancement or LGE and the myocardial perfusion imaging. Let's begin with the principle of LGE. As you know, gadolinium is a key component of MR contrast. Sorry. It accumulated in area where biocytes are lost as impraction. So this area related to high signal intensity of the MRI with the gadolinium accumulation. So as a result, infarcted myocardium appears white, while normal myocardium remains dark. As you can see, these MRI images, the area indicates the definite myocardial infarction. So myocardial infarction usually starts in the subendocardium and progresses toward the epicardium. So LGE allows us to distinguish between the subendocardial and the subendocardial infarction. The cutoff of the differentiating between them usually set as 50% of the wall thickness of the myocardium. The extent of infarction correlated well with the likelihood of the functional recovery after revascularization. So, subendocardial infarction may show the wall thickening after treatment. However, transmural infarct do not recover regardless of revascularization. This graph shows the comparison between the before the revascularization and the follow-up. So, subendocardial infarction shows the remarkable increase in the wall thickness. But the transverse infarct shows persistent wall thinning and without wall functional recovery. So if you see these MR imagings, you can predict the response of your treatment. Here is a case showing the transmural infarction with microvascular obstruction or MVO. Here is the MVO in the imperial wall. MVO refers to the central core area of impact where contrast gadolinium does not penetrate and approach. So this image shows the before the revascularization, and this 6 images shows the follow MRI after revascularization at 2 months. After 2 months, this infarction is the transmural impact with the MVO transfers to the definite transmural infarction and with the wall thinning. This wall thinning and the transmural infarctions can make us predict it can be associated with the aneurysmal change or ruptures in the future during the follow-up. So viable myocardium suggests potential benefit from revascularization. In contrast, areas with transmural impact, definite LGE, irreversible and persistent injury. So LGE, therefore LGE plays a very important role in guiding treatment decision. In my clinical practice, when I lead an MRI, I personally identified transmural infarction of LGE and counted the numbers of the affected segment of transmural infarction, and then finally calculated the total percentage of the LV wall involved. This gives us a visual and a quantitative overview of the impact burden. So as you can see, this LG map. This is LG map, and you can see the multiple blue areas of indicating the transmural impact. These blue areas total segment count is 6. 6 segment of transmural infarction, and the total LG is 10. account of about 45% of the entire left ventricle wall. This quantitative insight have predicted functional recovery and guide the treatment planning. One study shows that the patient with the use of the MRI in the basement of the CAD patient, the greater than or equal to poor transfer impact segment, it has a limited improvement in cardiac function even after successful KOVAS. This highlight the predicted value of LGE prior to surgery as well as PCI. Even after successful revascularization, the risk of sudden cardiac death remains, especially when scar burden exceeds 25% of the entire LV wall. This patient may require the further evaluation for the assess of the risk, sudden cardiac death risk, and prevent device therapy such as ICD. The sudden cardiac burden cutoff value is 25% of the total LV wall as LGE. So this risk seems to from the border zone. Border zone, it means where the viable and the impacted tissue exist. It is an arrhythmogenic area with the unstable electrical conduction. That means larger impacts increase this border zone, and ICD implantation may be clustered in such as this high-risk patient. Here is a clinical case. A 40-year-old man present with chest pain, and he was diagnosed with total LAD occlusion. And PCI was successful. PCI achieved the successful circulation in LAD. However, unfortunately, CMR result is unhappy. Shows unhappy finding. CMR reveals transfer infarction with MVO. This you can see these dark areas of MVO in the transfer infarction. In the transfer impact with MVO involved totally 6 LV segment. And in this patient, totally 45% of LV wall shows the transfer definite LGE. So that means that despite a successful revascularization, PCI, this patient may have a poor prognosis, heart failure, myocardial rupture, or arrhythmia, or ventricular tachycardia, and sudden cardiac death. So it means that this patient has a poor long-term prognosis. To summarize, briefly summarize, ACSM clearly differentiate viable from impacted myocardium. So infarction indicates irreversible damages associated with the poor recovery, functional recovery, and the increased arrhythmia risk. Next, I'd like to talk about perfusion imaging. Perfusion imaging visualizes the myocardial blood flow following contrast injection. Contrast means the gadolinium contrast media. Regions with poor enhancement, like this, poor enhancement suggests ischemia with impaired perfusion. Yes, the perfusion MRI occurs usually 1 image per 1 second. This perfusion image is required about 1 minute complete these images. So we can quantify the signal intensity changed over time about 1 minute to assess the degrees, the perfusion, and the peak and the slope. And based on these findings, that we can identify the ischemic segment. This graph shows the signal time curve showing the dynamic contrast enhancement in the myocardium. The blue dot blue dot represent the contrast within the vessel of the myocardium, and this time passes, contrast distribute into the myocardium. With early and the late phases, the dynamics shows the basis of the MRI, and early phases images indicate the perfusion, and the late gadolinium is based on this distribution of extravascular areas of myocardium. Beyond the perfusion, resting perfusions, stress perfusion is very important and very useful. And stress perfusion, stress is indicate the hyperemic status in the myocardium, and it highlights ischemic segment more clearly. So comparing stress and rest perfusion have assessed the significant coronary artery disease. So ESC guideline recommend the stress CMR as a class 1 for ischemic evaluation. About perfusion MRI protocol is some looks of complex. Perfusion MRI complex involved two different scans, first performing a stress perfusion and followed by about 15-minute interval wait before the rest imaging to wash out the stress vascularization. This image shows the clear perfusion defect in the inferior wall of the left ventricle, and this defect has been resolved, disappeared on the rest images. So this comparing with the stress and the rest can help us identify and diagnose the myocardial infarction beyond the infarction, myocardial ischemia. However, several studies comparing stress perfusion, and CMR. CMR result shows very excellent performance in the diagnosis of hemodynamically significant CAD, especially hemodynamically significant coronary artery disease confirmed by invasive paper. Between them shows a very high correlation, paper, and the ischemic defect. So stress perfusion effectively detect the significant coronary disease where the sensitivity is 90, specificity 95, and other performance is very excellent. However, despite its better use of the stress perfusion, CMR perfusion has several limitations. First, adenosine. Adenosine use can be difficult in the aspect of the radiologist. Second limitation is the protocol is very complex. As you know that we have to perform the two different scans and with the time interval required time consuming. Last limitation is the quantitative analysis. This quantitative analysis has low reproducibilities in routine practice. This slide covers my presentation. CMR cardiac MR evaluate the myocardial tissue characteristic beyond the coronary arteries itself. So as it predicts the functional recovery and arrhythmogenic risk of the sudden cardiac death, and stress perfusion can help detect the ischemia. So together, all of this guide the treatment decision, especially in the coronary artery disease and heart failure patient. Thank you for attention.